idea behind this document, the global idea behind this document is the achievement, the improvement of women's health and the achievement of goals set by the United Nations with the Millennium Development Goals number 5 that sets 2 targets, which I'm presuming for journalists that like numbers, so it's important for them, that set 2 targets, reducing the maternal mortality ratio by 75% between 1990 and 2015, and achieving universal access to reproductive health by 2015. Today, so far, the reduction is about 47%. In 2010, the estimate for maternal death is of 287,000 persons with a decline by 47%, and Sub-Saharan Africa and Southern Asia accounted globally for 85% of the global burden. So this is something that has to be taken into account. When talking to Sir Professor Arun Kumar this morning, he made a couple of other examples that may be useful to remember. I remember one about Mozambique. You said that it is a lesson to learn, as many other stories like Dr. Ozeva presented are lessons to learn in this report.
Yes, I think in this particular report we have highlighted, for example, the use of misoprostol. Misoprostol is a medication given for peptic ulcer normally, that can be used also to contract the uterus after childbirth and to stop the womb from bleeding. Normally we give a medication called oxytocin, which has to be given by injection, and it has to be stored in the refrigerator. Whereas misoprostol in a blister pack, and it can be given by midwives, and where there are no midwives, sometimes we are given also to the individual mother, and it seems to be effective in these situations. The Mozambique story is not highlighted in detail, but it is that there are 20 million population, and there are about 62 obstetricians and gynecologists. So there are not enough obstetricians and gynecologists to perform cesarean section. So one of our colleagues from Sweden, Stefan Bergström, when he worked there, he trained midwives and other scientific graduates to do cesarean section. They're called surgical technicians who can do cesarean section safely, and thereby they can go and live in the periphery and help mothers dying because of uterine rupture. So these are just examples. Misoprostol to reduce, because 35% of maternal deaths are due to bleeding. And Andre Lalonde, who is our chair of the Save the Mothers and Newborn Committee, has produced some guidelines on behalf of FIGO with the help of WHO and ICM, and that is also given to the delegates this time. So these are examples which can be used, low cost, low technology, task sharing, task shifting, all these things. A number of things have to come into play if we're going to reduce maternal death.
Francis Desi has to leave for a presentation. So thank you for coming. Thank you for coming. Any question about any curiosity, anything else, or if you have anything to add, maybe some other practical examples.
Well, just to add in terms of what alluded to Mr. Chair, what needs to be done, or what are the trends, because you mentioned the figures on the MDGs. The results we saw are an average annual decline of 2.3%. In order to achieve the MDGs, to meet the targets which are set, we need on average a decline of 5.5%. In sub-Saharan Africa, that in the region on average it's about 1.7%. So we are still far, although the figures may be low, the job has not been done. There is still much to be done. No life should be lost during pregnancy or childbirth. it's very good that we are witnessing this political commitment. We have countries where there are examples which shows that it does work, it can happen when efforts are made, in particular at the political level. Thank you.
Well, just to underline what Sir Rokaman said about misoprostol, that the most frequent, you were probably all aware of that, but the most frequent reason, of course, for women dying is that they bleed to death, and that is, 24% of all the maternal death reasons. In Eritrea, it was even up to 50%, and therefore concentrating efforts on being able to respond to that situation where the uterus doesn't contract and then this leading to death by bleeding is of great importance. And Dr. Lalonde and others have really helped to develop guidelines and stepwise approach in these emergency situations.
Please.
Thank you very much for this presentation. My name is Birgitta Hysén and I'm a lecturer in Uppsala University. And Professor Rosling, the great gapminder, is also from Uppsala. And I listened to him for quite recently when he gave one of his speech and slideshow showing that religion and religious beliefs has actually nothing to do with reproductive health outcome, and it was not related. It was a little bit surprise for a lot of people who worked in the fields and so on. And I can notice that you have not the cultures or religious aspects in this report. But however, yesterday when we took part of the opening session, FIGO gave a lot of example of seminars and collaboration with religious leaders, and there was a lot of photos from these meetings and so on. So obviously FIGO has an approach and have an intention working with religious leaders, and so what do we think about religious beliefs related to reproductive health outcome?
Well, I think the essence is actually there are a lot of myths and misunderstandings about a number of issues related to sexual and reproductive health. For example, if you go to South Africa, they believe that if a woman uses a contraception, for example, the man will become impotent or something like that. It's total, I mean, when you think about scientific evidence, you will think it's a total nonsense, but that is what they believe, that they will become important. So they prevent the woman using a contraception. Somebody else, and this was told by one of the ex-health ministers from South Africa, who was in a pre-Congress seminar. He gave a number of examples of these myths. And the myths sometimes, when we as professionals go and tell the public, they don't want to listen to us because they think we are behind trying to promote contraception, condoms, IUCDs, and so on. On the other hand, when we explain to the religious leaders by giving contraception, you're going to prevent an unnecessary or unintended pregnancy, which will go for miscarriage or termination of pregnancy and so forth. The mothers are dying, and therefore you have a role to prevent that. Or she will become anemic due to repeated pregnancies, or she might die of PPH. Then they do understand, and when they go and tell, then the public are able to believe. I mean, for example, I'm from Sri Lanka. Abortion is illegal there, and the third highest cause of maternal death, although their maternal death is low, about 34 per 100,000, the third cause is illegal abortion, and it's unbelievable, but that's the case. So how do we prevent that? So we have to put a primary prevention strategy with contraception before they get pregnant, secondly when they are soon after delivery or soon after abortion, and so on and so forth. So the question you raise is a very important one. We will try to work as closely as possible with teachers, with religious organizations, community leaders, and so on, because they have to give the lessons about the importance of a girl child, the nutrition for a girl child, for example, the education for a girl child. Because in many communities, they prevent the girl from going to school. Once they start menstruating, they say, that's fine, now she has to get married. So they don't understand it. And even if it is married under 20, how can you postpone a pregnancy if it's married for beyond 20? So some of these things actually are better communicated and easily communicated through religious and leaders, community leaders and teachers. So I think there's no single magic bullet. We have to work in different ways. So I think your point is a very important one. We have started doing that, and we have to expand a little bit more on that.